Hello, good afternoon. I'm Ann O'Day from the University of Kansas Cancer Center, and I have the pleasure today of moderating our multidisciplinary breast cancer tumor board. And I'm going to ask our faculty to each introduce themselves. We have some very distinguished faculty with us today. So we'll start out with Dr. Joyce O'Shaughnessy.
Joyce O'Shaughnessy, Baylor University Medical Center, Texas Oncology, and U.S. Oncology, and I'm chair of the U.S. Oncology Breast Cancer Research Program.
Hi, Terry Mamines, breast surgical oncologist. I work at Orlando Health Cancer Institute in Orlando, Florida, and also chair the breast committee for NRG Oncology.
Hello, I'm Dr. Frank Muccini, radiation oncologist. I work for Genesis Care in Michigan.
Hi, I'm Dr. Maxine Chalkelson. I am the Director of Imaging at the Evelyn Lauder Breast and Imaging Center at Memorial Sloan Kettering Cancer Center, and I'm a breast imager and a PET reader.
A 60-year-old woman with a T1cN1a invasive ductal carcinoma of the left breast, ER and PR positive, HER2 negative, and there is a margin positive for ductal ectasia. One of four lymph nodes were sentinel lymph nodes were positive, and this patient has had a 21-gene recurrence assay with a score of 14. And so the questions being posed is, does the presence of the margin with duct ectasia necessitate re-excision? And should regional nodal irradiation or boost be offered in terms of her adjuvant therapy? So this patient presented with a palpable left-sided breast mass. She has an excellent performance status, just a little bit of hypertension. She's postmenopausal, drinks wine daily, and her family history she has one niece who succumbed to breast cancer at the age of 30. In January of 2021, she presented with this palpable breast mass. We're going to have some imaging here in just a second, but the biopsy demonstrating invasive carcinoma. She did not have a breast MRI. And we might just have Dr. Jockelson show us the imaging here.
Sure. So predominantly fatty breast. She does have a spiculated mass that has arrows on it that corresponds to the history of where her carcinoma is. And, it looks like a T1 lesion probably. And I'm not sure why they did a bone scan. T1 lesion negative, I think no notes. Don't know why. I don't have the bone scan. I don't know if she was symptomatic or anything. But that's it. So basically unicentric unifocal cancer.
Okay, so she did actually, Dr. Jockelson, have 1 out of 4 sentinel lymph nodes that were positive.
Right, but she
I'm
still,
so sorry, I didn't.
She still doesn't really qualify for the standards for doing any systemic staging with a T1N1 lesion. But she may have symptoms or something like that. I just don't know.
Perfect. Okay, thank you so much. So she underwent the lumpectomy and sentinel lymph node biopsy again, which demonstrated a 15 millimeter grade 1 invasive ductal carcinoma, the inferior margin demonstrating ductal ectasia. 1 sentinel lymph node was notable for metastatic carcinoma. There was no extracapsular extension. The prognostic markers demonstrate the estrogen receptor 90%, progesterone receptor 95%, HER2 negative, and a Ki67 of 20%. Her 21-gene recurrence score demonstrated a score of 14. And I might just have Dr. O'Shaughnessy comment on what you feel like is the benefit of genetic testing in this patient that has a niece that was diagnosed with breast cancer at the age of 30. Would that be something that would prompt you to consider genetic testing?
I'd certainly talk to her about it. If that was an isolated case, we don't know that it came from her side of the family. It could come from her niece's other side of the family. But I would talk to her about it and kind of lean her towards it. These days it's not an expensive test these days, and so I would lean her towards it. But people have strong feelings one way or another about genetic testing, and I wouldn't push it per se, but I'd probably be encouraging of it.
Okay, thank you so much. Dr. Mamunis, can you comment about the presence of ductal ectasia at the margin?
Well, I think to my understanding, ductal ectasia is a benign finding, so I wouldn't worry about the re-excision based on that. If there's no cancer on the margin, I think she's fine. I would not re-excite.
Okay. Perfect.
And also, with the sentinel nodes, she would fit Z11 criteria, so I would not feel compelled to go back and do an axial dissection. I think breast radiation should be good enough, but I'll let Dr. Vicini comment on that.
Perfect. Dr. Vicini?
Yeah, totally agree with Terry. I wouldn't ask for re-excision in this case. I wouldn't even use a boost for the whole rest of radiation. With respect to the regional nodal treatment, as Terry said, she fits the 11 criteria, so probably just use high tangential field. Certainly wouldn't change the superclav in this particular patient. So again, no re-excision, don't need a boost, and just high tangential fields for the radiation therapy.
Okay, perfect. And Dr. O'Shaughnessy, do you want to comment about what you feel like would be her optimal adjuvant systemic therapy? So again, we have the 21 gene recurrence assay with a score of 14. We have only one positive lymph node. And can you sort of walk us through your thinking and how you would approach a patient in this situation?
I do like to see concordance between the kind of clinical pathologic features and the 21 gene recurrence score. Pretty much they're concordant. It's grade 1 disease. It's ER and PR both strongly positive. The 21 gene recurrence score is low, and so that's great. The Ki-67 of 20% is a little bit of an outlier. It's not terribly high. I see this quite frequently, where the Ki-67 will kind of be intermediate, but the 21 gene recurrence score comes back low. I think it's just the differences between the tests, of course, but the 21 gene recurrence score has 5 different genes, including Ki-67, in their proliferation panel. So it just may be that by the time you look at 5 different genes, it modifies the effect of the Ki-67. But we know Ki-67 is quite variable in being read. So I'm comfortable that the biology of this cancer is concordant with the 21 gene recurrence score of 14. And we do know from the R-exponder data that she's very unlikely, if not likely, to benefit from chemotherapy. So I would talk to her about 5, probably 10 years of endocrine therapy. I'd be interested in Terry's point of view here. Our NCCN ASCO guidelines really say for node positive disease, generally consider 10 years of endocrine therapy, and I would certainly I'd usually recommend an aromatase inhibitor. With this kind of biology, I'd be okay. However, starting with tamoxifen, if the patient had, having gone over the risks and benefits, as long as there's no contraindications to tamoxifen, but if she had, significant vaginal dryness, or she had, osteoporosis, et cetera, I wouldn't be adverse to starting her on tamoxifen and switching her over. I do tend to use zoledronic acid every 6 months for 3 to 5 years, per the Oxford meta-analysis, showing an improvement in both disease-free and overall survival with, the bisphosphonate. So I do tend to recommend that as well. But I'd be curious with Terry. Terry, do you ever, obviously from the B42, I think you showed, the higher the risk, the more likely they were to benefit from the 10 years of aromatase inhibitor therapy. And this woman, has one node, but her biology is pretty favorable. What do you think about this? And I guess, are you using yet any of the the BCI, EndoPredict, ROR type scoring yet?
Yeah, so I agree. I mean, she's a little bit of higher risk because of the one positive node. On the other side, though, she's on a low risk because of the oncotype of 14. So that kind of negates a little bit of that. And the benefit wasn't necessarily all that much more in B42 for no positive patients. The risk was higher, but the proportional reductions was about the same. But the benefit actually it wasn't double if you were no positive, let's say, than if you were no negative. The other thing that becomes apparent from the extended therapy trials is that maybe 10 years is a little bit of an overtreat. Maybe you can get away with 7 to 8 years, as there were studies comparing 5 to 7 or 8 that did not show significant benefit. So by extrapolation, you can say maybe 7 is probably as good as 10. So you can push her for a little bit more, but don't even have to go to the 10 years necessarily if she had tolerance problems. The genomic classifiers obviously predict risk of late recurrence. The BCI has been shown also of predicting extent of benefit from, the magnitude of benefit from extended endocrine therapy. So when you get to that point, you could use something like BCI to determine whether she, besides whether she's high risk based on the BCI score, and whether she receives benefit based on the H/I ratio of part of the BCI. But again, I think we're talking probably for about a 2-year difference, 2 or 3 year difference, extending it to. That's what I would aim for.
Yeah, the ABCSG 16, I guess, it looked at 10 years versus, was it 7 years? 7 years total of endocrine therapy, right? And it was the 10 years was not better than the.
I think, if I remember correctly, it was 5 versus. It was 2 versus 5 more, right? Yeah.
Right, exactly. They had already had 5, right. 2 versus 5 more, right. And so, yeah, in that particular study, but the national guidelines are leaning us towards 7. But that's, I think we can flex it a little bit for each individual woman. Was the kind of thing I wanted to kind of see if you agreed with that, because I wouldn't feel in her particular case that, you know, going to 10 versus a 7 would make a big difference, you know, for her. But I do look forward to B42 results, you know, looking at some of these genomic classifiers.
Right, and going back actually because since she has an oncotype already, if she's high ESR 1 level, then what we've shown is that that predicts for these patients, oncotype predicts risk of late recurrence. It doesn't predict in the lower ESR 1 levels, but with the higher ESR 1 levels, if she is that, and you can find out from the test, when you get to the point, I think we've shown in B14 and B28 that actually she could be a low risk for late recurrence based on the oncotype test.
Great, thank you.
Perfect. And Dr. O'Shaughnessy, if you might just comment, how would you, if this patient did have 5 lymph nodes involved, so sort of if she didn't fall into the responder, you know, eligibility criteria, which was, you know, less than 4 positive lymph nodes. So let's say she had 5 positive lymph nodes. How would your approach for adjuvant systemic therapy, given her 21 gene recurrence assay is favorable at 14, but then you have this, you know, more than 4 positive lymph nodes? How would you approach a patient in that situation?
This is a very difficult situation because we don't have data specifically in this group of patients. There's a trial going on in the UK, an important trial called the Optima trial. And one of the eligibility criteria are patients with 4 or more nodes, and they undergo the ROR PrecisCa score. And if they come back low risk, they can be randomized to chemotherapy, no chemo. They are randomized to chemotherapy, no chemotherapy, just like the RxPonder trial, but it's for 4 or more nodes. So we really need those data. And the fact it's enrolling well, and the fact that it is enrolling well, and that, you know, consensus of experts said we have, you know, therapeutic equipoise here to be able to randomize patients who are low, you know, favorable biology, you know, low risk by a genomic classifier, and we're willing to randomize her to chemo, no chemo, tells you that I think that is a hypothesis whose time has come, you know, to be looked at. Having said that, we don't have the data yet, and we do know that women with 4 or more nodes have a poorer prognosis. We also have some data that were a little sobering from the West German study group ADAPT trial that was presented at San Antonio, where patients received just a window of preoperative, couple of weeks of preoperative endocrine therapy, aromatase inhibitor therapy, and if their Ki67 was very suppressed, you know, down to less than 10%, and they had a 21 gene recurrence score, you know, under 25, then they were not treated with chemotherapy, and 1 to 3 nodes were allowed, and they followed the patients, I think a median of about 5 years or so, and the node negative and the 1 node positive, even 2 node positive, did well with endocrine therapy alone. But for the 3 nodes positive, it was only a disease-free survival around 75%. There was a real fall off there. And so she is high risk. The problem is you can be high risk and not benefit from chemotherapy. That's the real dilemma, you know, that we're all seeing. Having said all of that, she's 60 years old, and if otherwise healthy, I would recommend chemotherapy to her. That's been my standard practice in a very high risk person. So I generally recommend standard AC followed by weekly paclitaxel. As I was thinking about this case, I was thinking about the MIND-ACT trial. There was a sub-study of the MIND-ACT, not a large study, but patients were randomized, if they were getting chemotherapy as part of the MIND Act, they could be randomized to, I believe it was the EC or AC. I think it was followed by docetaxel versus capecitabine and docetaxel. So the XT regimen for 6 cycles. And in this particular study, it wasn't large, but there was no difference between the two. And sometimes in the face of indolent biology like this, I don't know what the role of DNA damaging agents is, particularly the doxorubicin. And so I would probably consider that in this patient, just discuss the options. So I would end up recommending chemotherapy to her. And if she were somebody who, were adverse to a standard regimen of AC followed by weekly paclitaxel, I wouldn't be concerned about giving her an alternative. But my recommendation would be standard chemotherapy of AC followed by weekly paclitaxel.
And if she was averse to an anthracycline, what would be your preferred alternate regimen and the number of cycles?
So we could do the docetaxel cyclophosphamide. In the ABC trials, in patients with 4 or more nodes, the 6 cycles of docetaxel cyclophosphamide was inferior to an ACT-like regimen. We do have data from the MIND Act, as I was saying, that looked at docetaxel and capecitabine. And it was 6 cycles. It was 6 cycles. And there, in a small trial, not as big as the ABC trials, there was equivalence between a kind of a ACT and a capecitabine and docetaxel. So I probably, if she were averse to it, let's say I would probably have to think about it just a little bit more, but I probably would. I'm also thinking about another, data set, which was also it's a Plan B. The West German study group Plan B study also looked at node negative and 1 to 3 node positive patients and ER positive patients. It was a mixture. There was a 19% were triple negative, but mostly were ER positive. And they did compare 6 of the docetaxel cyclophosphamide to an ACT regimen, and they showed equivalence. So, but it wasn't 4 or more nodes. I guess I think there's a higher level of evidence with the docetaxel cyclophosphamide if we bring in the Plan B study as well. And so I'd probably recommend the docetaxel cyclophosphamide.
But 6 cycles, not 4. Is that correct?
Cycles. 6 cycles.
Perfect. Okay. And we'll ask for one other sort of variation, because this is such a salient question, given the recent responder data. And I think we've seen a big shift in the way we're all practicing for our node positive patients. This patient, of course, that we were discussing was postmenopausal. But what if this patient was a 43-year-old premenopausal female with just the one positive lymph node with an Oncotype score of 14? What would be your recommendation for that person if she was really strongly premenopausal?
Yeah, another controversial area, right? But these are real life cases, aren't they? So, the RxPonder data, as well as the MIND Act data, showed that in premenopause, and to some extent as well, the TAILOR-X trial, although it was the higher end of the low end of recurrence score, 16 and above, pretty much, showed that the premenopausal patients benefited from adjuvant chemotherapy. However, in all those trials, the percentage of patients who had optimal endocrine therapy defined by today's standards, not by the standards that existed when the trials launched, a very small minority of patients had an LHRH agonist. So it really begs the question, would this patient be a candidate for optimal endocrine therapy instead of chemotherapy? And do we need a randomized trial on that? I know Terry's interested in one. Terry's nodding his head. He thinks I think it is an important question. Here's an example. So in this particular case, again, I'm looking for concordance between the clinical pathologic and the 21 gene recurrence score 14. I think I'm pretty comfortable that it's there. If this patient were willing to take if I felt that she would be adherent to an LHRH agonist or even to a BSO, which frankly would be my preference for her, because I'm going to want her to have extended adjuvant therapy. And if she would take an aromatase inhibitor, I guess I'd even be okay with tamoxifen for a while and switching to an aromatase inhibitor. If she would take optimal endocrine therapy and IV zoledronic acid, this is a woman I would put that option on the table for. I really do think that at least some of the patients benefited from chemotherapy in the MIND-ACT, the R-Exponder, and the Taylor-X because of ovarian ablation with the chemotherapy. So that's what I would do. That I would have a comfort level in this particular case with one positive note.
Are any stopping to do an oncotype in postmenopausal women who are presenting now? I mean, based on the data from these trials, so an average presenting, not a real high risk or whatever, but I mean, it seemed that from the data, there's not much reason to do an oncotype score for somebody who doesn't have some red flags or something like that, because you would give them chemotherapy anyway. Are people stopping to do it?
I don't know that it's really wound down that much yet. I think the data are still pretty new, but I certainly take your point. The thing about the the 21 gene recurrence score is that we've seen a lot of data with the the low, the former intermediate and the high, and like you think, oh, it's grade 1, but it can still come back high, or it's ERPR positive, it can still come back high. So there's been some variability in terms of the concordance with clinical pathologic features and the recurrence score. Now, I think as women are node negative and they're lower risk, I think that I only send it honestly when I'm really unclear. That if I really don't think the woman's going to benefit at all, she's really very fair, I don't send it in the node negative. I think I'd still do in the node positive because she's just higher risk of recurrence. I just want to make sure I've got all the data on the table if we're going to do a de-escalation strategy.
And Dr. O'Shaughnessy, you mentioned the data, the ADAPT trial. And I think one of the things that really bothered me about that trial is that if you look at the very young patients in that trial, regardless of their Oncotype score, they all benefited from chemotherapy. Like even the patients that had an Oncotype score of 8 or 9, there was still a benefit of chemotherapy if they were very, very young. So I guess what I struggle with this, and I think many of our clinicians that are watching you today, is that when you have, for example, a 43-year-old patient that only has a 1.5 centimeter tumor, but already has a positive node, right? So it sort of suggests that, that might be a patient that potentially there's, that potentially could be a sign of a more aggressive phenotype. How do we, in the absence of really randomized data, how do we feel comfortable not giving or at least recommending adjuvant chemotherapy for those patients? If you could just walk me through your thought process on that.
I don't think there's really any difference between the biology of a node negative, like a 1.5 centimeter, let's say node negative, and a 1 node positive patient. In fact, I'm just remembering a data set from Sam Hellman from the University of Chicago. They had 20-year follow-up on this massive number of patients at the University of Chicago. And, there really wasn't much difference in outcome at the end of the day between node negative and 1 node positive. Now, it's different as you get more nodes. That's a different matter. But the biology to develop a lymph node positive is metastagenicity. In this beautiful JCO paper from Sam Hellman from 20 years ago, he distinguished between virulence and metastagenicity. And virulence is proliferation, and metastagenicity is the machinery that the cell uses, the mesenchymal biology that the cell uses to move. And that's very different, and that doesn't predict for chemotherapy benefit. Virulence predicts for chemotherapy benefit. And as we know, the 21 gene recurrence score is really based mainly on the proliferative status. So I separate those in my mind, and I am just it's because I don't think there's a difference in the biology of a 43-year-old who's node negative and a 43-year-old who's 1 node positive, and she's got 21 gene recurrence score of 14 in both situations. I don't think about them differently in terms of the benefit of chemotherapy.
So,
perfect. Okay, that's very helpful.
comment real quick. I mean, I think there's several sort of pieces of information that point us that the benefit in the premenopausal may be endocrine related, right? First of all, the SOFT trial had shown that even in high-risk patients that received chemotherapy, ovarian ablation gave them a benefit of almost about, I think, 6 or 7%, right? So that's on top of whatever chemotherapy benefit these patients had. And this was unselected for recurrence score. They were all comers, right? And then also, speaking of the ADAPT looked at pathologic responses in the neoadjuvant group. And essentially what it showed was that pathologic responses in premenopausal were only 5%. If they had a recurrence score of less or equal to 25. And other data sets have shown also that you don't get pathologic complete responses pretty much under the recurrence score of 25. And lastly, the B14 data showed that the benefit from in recurrence score low and intermediate patients, there was endocrine therapy benefit, wasn't in the 30 and above. So all this point out that this is an endocrine sensitive disease and potentially the chemotherapy is ovarian ablation. But again, these are arguments that I think we have to put to a randomized trial.
Mm-hmm.
I think it's time for this. It's the last piece of the puzzle, I think, at this point.
I do think so, because I think what the question Anne just asked is very, very much in people's minds coming out of the responder data. And I think that there's most docs and patients would say, hey, let's just go with the responder data and let's just go with chemotherapy. And I think that's really become more of a standard, but it wasn't my standard before the responder data. And I haven't really felt like I should back away from it. Now, again, in the setting of very indolent biology.
Yeah.
Okay, that's really helpful. And I think just to go back to something Dr. Jockelson asked, I was curious, Dr. Mamunis and Dr. O'Shaughnessy, how you all are approaching. I know at our institution, we're actually starting to consider more assessment of 21 gene recurrence scores on biopsies if we have a postmenopausal, what looks like maybe 1 or 2 node positive, where there's a larger tumor and there might be a benefit to a neoadjuvant chemotherapy. The thought being that if you do the oncotype and the oncotype is very high, for example, that you might approach that patient with neoadjuvant chemotherapy. Do you, at your institutions, are you at all doing that on the biopsy specimens for patients with limited nodal disease, or is that not something that you've adopted?
We've not adopted it. There are some data that really do suggest that the 21 gene recurrence score, can be a predictor, as Terry just mentioned, with regard to chemotherapy sensitivity in the preoperative setting as well. And sometimes the goal isn't PAF-CR, the goal is, cytoreduction, to be able to get the patient to a surgery that will be more successful for the patient. And there it's certainly not unreasonable. I tend to, I guess, mainly to go by clinical pathologic features. Again, if somebody's, a classical lobular and she's postmenopausal and it's ERPR strongly positive and it's lower grade and low Ki-67, the chances of her getting substantial cytoreduction from chemotherapy is very, very low. And so I would go with endocrine therapy for that patient alone if she needed cytoreduction to get to surgery. Conversely, if she's higher grade, of course, et cetera, then we would go with chemotherapy. So I think it's a very reasonable way to put that information into the equation. Quite honestly, the data are still limited, but I think they're growing.
Yeah, and I agree. I think now with the responder trial, I mean, you can actually say, well, in a premenopausal patient, let's say that presents with a T2N1 tumor, you're not going to get away from giving her chemotherapy, at least based on what we just discussed. On the opposite side, though, for a postmenopausal patient, then you could avoid chemotherapy if, let's say, she had a recurrence score of 12. So doing it on the core biopsy, particularly in postmenopausal, can actually give you 2 options then. If she's low recurrence score, then you can either give her neoadjuvant endocrine therapy and then do surgery and continue with endocrine therapy if it doesn't have more than 3 nodes. Or given, if it's a high recurrence score, start with neoadjuvant chemotherapy or just do surgery followed by adjuvant chemotherapy. I think those options are there. But if you really want to downstage and you know that she's a high recurrence score, she's going to get chemotherapy anyways, might as well do it in the neoadjuvant setting. On the other hand, if there's a low recurrence score postmenopausal patient, you can just say either endocrine therapy if I want to downstage you, or surgery first, followed by just endocrine therapy if your nodes are 1 to 3 and not more than that. So I think for premenopausal patients, it's a little bit more difficult because you kind of think you're going to give them chemo anyways. For those patients, you can say, let me downstage, and then we can do the recurrence score. And then you can always, if you want, do the recurrence score on the core.